Welcome to Association Chat, an online discussion for the association community where we warm ourselves by the virtual fire with topics of the day, welcoming thought leaders and trailblazers alike to join up in this online home for the association community. I'm the host of Association Chat, Kiki L'Italienne, and today we're talking with medical ethicist and science journalist Harriet Washington. She's the author of notable books like Medical Apartheid and A Terrible Thing to Waste, Environmental Racism and Its Assault on the American Mind. And we're going to talk with her about a number of things, primarily about how racism plays a role in healthcare inequities and what we can do about it. I want to start off, Harriet, by saying thank you so much for joining us today. I know we were talking a little bit before we got started today. Your phone must be ringing off the hook. There is so much that is happening in the world right now that needs your expertise. I really appreciate you taking the time to talk with us today.
Thank you for having me, Kiki.
So I wanted to start off with something so that we can understand a little bit more about you, because you have a wide variety of information, books that are out there that now I was reading how one of your books, Medical Apartheid, is being taught in medical institutions now. And I just wanted to get started with asking you how you got started focusing in on some of the topics that you do.
Oh, well, I'll try to answer that question. I actually became interested long before I was a writer. When I worked in a hospital, teaching hospital of the university I had gone to, I worked in the poison control center, and eventually I became the supervisor. And I came across an old file cabinet, as I described this in the introduction to Medical Apartheid, an old file folder filled with files from kidney transplant candidates. Kidney transplantation had been a new technology at the time these files had been compiled. And I was immediately struck by how they looked very different. There was a set that looked very thin, with a few papers, and others that were very thick. The thick ones were filled with documentation to support the candidacy for a new organ, a new kidney. The thin ones were not. And many of the thin ones had social profiles, and the ones of the Black patients had the word Negro on the social profile underlined, and they tended to be the files that did not have the thick sheaf of documentation explaining that the person had insurance, a loving family to support them, stamina, etc., was a good candidate. And I thought, could it be that the sheer difference of the races they belong to, could that be indicating that? And of course, you can't, even if that were true, you can't prove it with a sheaf of files, right? They might not have been representative, but it was still very troubling to see. And it reinforced other things you can't help but have noticed in the hospitals in 1980s. In the early 1980s, the late 1970s, there was a lot of racial bias, and it was obvious. You know, not only the paucity of Black physicians and scientists, but, you know, on the staffing, the directors of departments, they were almost all whites. And so, and whereas the housekeeping and clerical staff tended to be Black and Hispanic. So, it was rife. It was in your face, and yet no one was talking about it then. That was not considered an issue of importance, especially for medicine itself. You know, they would focus on things other than race. And when they did talk about race, it was often shrouded in socioeconomics, right? Still happens today. Anyway, I talked to someone who had worked in the kidney transplant unit, an African-American woman, very sharp, very smart. It turns out she was actually a pre-med student as well. And I said to her, could it be race? And she looked at me and said, of course it's race, you know, as if I were an idiot, you know. And she said, and then she went on to have like this minor informed rant about the hospital, ending by saying, I would never have a procedure done here. I've seen too much.
Wow.
You know, just an intelligent person. And it was very troubling. And so the more I thought about it, the more I began asking people I worked with. And some of them were actually pretty open and forthcoming, but nobody people were saying, I feel that's true, but there's really no data, and it just might be my feeling. And I thought to myself, that's part of the problem. I went to the medical library and there was no data back then. And I thought to myself, someone needs to collect this data. Someone needs to quantify this so we know exactly what's happening and why. Until we do that, we'll have nothing but, suspicions and abuses. And for decades, I began collecting information about this, but not being a writer, I wasn't thinking about writing a book. I was thinking that maybe one day I would be the person to compile this data. I wasn't sure. But as time went on, and I began talking to the very people who should have known about this, people in public health, people in the history of medicine, and they all had these blanket denials. Oh, no, no, no. It's urban legend. It's paranoia. It's conspiracy theories, And they were able to say that because there was indeed no data. And that's when I determined, actually in 2001, at a conference in Lübeck, Germany, on the history of medicine, international supposedly, but there were no people of color there.
Huh.
And everyone I spoke to, every one of these experts all told me, no. Only thing that ever happened to African Americans was Tuskegee. That's it. But by then I knew that wasn't true. Mm-hmm. So I decided to write the book. And that's when I began, wondering about a lot of the information that is not curated in the history of medicine. It doesn't enter the canon. So people aren't aware of it. Not only in race, which is very important, but also in things like mental illness. My book about mental illness, Infectious Madness, focuses on infection as a risk factor for mental illness. Copious data, but for a long time, we just chose not to look at that. And those are the things that really fascinate me. What are the things, sometimes right in front of our faces, that we choose not to see, or we fail to see, but could have a big impact on our healthcare status?
Yeah, it's such an important question right now. And let me see, I'm getting a little bit of an echo, so I'm going to see if I can fix that myself. Let's see here. Okay. So it's such an important question right now, because we certainly are seeing where a lot is rising in stories that are being reported to the media, where they're saying, look, COVID-19 is impacting and killing more African Americans than we see killing whites right now. What is happening with that? Why is that happening? And, if we would take a page from your book and just take a look at it, it's been happening. And so there shouldn't be a surprise with that.
Exactly.
So what are you seeing now that some of these stories are starting to come up? I've been seeing pushback from people in the medical field and elsewhere, where they're saying, oh, but that can't be it. It can't be that, it has to be something else. It has to. What do you say? What's the most common pushback that you get when you start to ask these questions and say, yeah, but these reports look like there's a disparity that is signaling that there's something to do with racism or inequality in the way that people are being taken care of? What's going on?
Well, the pushback it's limited, but I think it's only limited because I tend to be, I think the polite way of putting it is meticulous. Some might say that I get a little bit overboard with documentation, but it's necessary. But the pushback that does emerge is all over the place. What it has in common is a reluctance to admit that racism, not race, but racism, is a driving factor here. Let's face it, it's simply uncomfortable thing to admit. It sounds a lot better to say it's socioeconomic, because then you can ascribe poverty, which no one can blame you for, instead of racism, which you can be blamed for. It also plays, unfortunately, into a subtle but real tendency to blame the victim for their own exposures. So I've actually heard from people who have said, well, it has to do not with race, but with where people choose to live. And then I have to point out, Well, if you look at the data, you find that people are not choosing to live next to toxic spewing factories.
Mm-hmm.
They're not choosing to live in overcrowded apartments overrun with vermin. People are there because there are decades of bias, segregation, mortgage redlining, and other factors that are still in effect that separate people of color from desirable housing situations and that concentrate toxins in communities of color, these sacrificial communities. So it just is easier. I think it's more comfortable for whites, particularly, to say that it's socioeconomic, it's not race, but yet we know it's race. One datum I use in my book to illustrate this is that if you look at income, if you wanted to say it was people's income, well, look at African Americans who earn $50,000 a year
Mm-hmm.
or $6,000 a year, solidly middle class. They're much more likely to live in areas that are exposed to heavy toxicity than extremely poor whites who earn only $10,000 a year. I mean, profoundly poor whites. So this is a national trend. So it's not at all, poverty. Poverty is indeed a risk factor, but it is dwarfed by race. It's a much smaller one. And let's not forget too, that today, you said something very important when you said we should have known. We should have known this. It's not an anomaly. What happened with HIV?
Mm.
It took a while to collect the data to find that the South was an epicenter of infection and that African Americans were more likely to be infected. And now in this country, it's a disease of people of color. Hepatitis C, 20% higher rates in African Americans. So when coronavirus 19 struck this country, one of the first things we should have done is collect adequate data, including data that would be racially stratified, to find out if these vulnerable groups were going to be profoundly affected, and indeed they are. And let's not forget the first message about people of color and coronavirus 19 was not that they had higher rates, but that they were immune.
Mm-hmm.
It's only been 6 months, but it's been 6 very frenetic months. Hard to remember that initially what we saw was African Americans believing that they weren't susceptible to coronavirus 19. And although you might think that's an absurd belief, it's not absurd at all. Because if you look at the news coverage, a lot of the coverage focused on the supposedly very, very low rates of coronavirus in Africa. There were very low reported rates, but you don't need to be a public health expert. Common sense will tell you that if you have a continent filled with many countries where people don't have good public health surveillance, of course you're going to have low numbers. There's no testing. We don't have good enough testing here in the US. They certainly don't have it in some of the poorer countries of Africa. So, it was foolish to think that they had low rates because they simply were not contracting disease. It should have been obvious that it was much more likely that they weren't being tested and that cases weren't being found. But the reason why people could accept this is a very long-standing belief since the 19th century that Black and white bodies are so different, that Black and white people have diseases that the other group doesn't get, and that Blacks are immune to some diseases. We have believed for a very long time that some diseases do not harm Black people.
Mm-hmm.
The 19th century doctor said, "Oh, Black people don't die of yellow fever," even though their own cases recorded many Black people dying. It was a belief based by racism, not by science. And so when we began asking why Africans were not susceptible, people were accepting that, when they shouldn't have. And so when African Americans did not see themselves portrayed in any of the early coverage, it was not that absurd for them to begin believing that they might be immune,
Yeah. I mean, I feel for people in a way because a lot of people, I think, they don't push back and ask the questions that you naturally do. When we look at how you started digging into all of this and really researching it, it was this curiosity. You had a question, you noticed something odd, and you began to pursue it. I think I think a lot of people don't stop and take time to sit with those questions when they arise. And so, I've noticed that, and a lot of people have been fighting back and forth about whether we should trust or listen to the medical experts that we have. And of course, it's very frustrating when we don't listen to the medical experts that we have. But it's also very difficult to see that there are people in the medical establishment who seem to push this idea about sort of racist ideas connected to genetics, And so how do you grapple with that yourself? Because on the one hand, you're wanting people to listen to the advice of qualified medical professionals. On the other hand, you're wanting to say, maybe you should ask some more questions about this.
Well, I think the first thing to understand is that holding an MD or PhD does not exempt you from having political, biases that can blind you to the truth. So you have to ask yourself who the medical professional is. A scientist may be extremely adept in his field, but he also may have conflicts of interest or beliefs or loyalties that keep him from generating objective data and objective analyses. So the fact that someone has won a Nobel Prize or has a PhD does not inoculate him against having racist policies or simply illogical beliefs or being so heavily politically motivated that he's willing to put his scientific scruples aside to espouse something he knows not to be true. So it's important to listen to experts in the field. It's critically important, but also ask yourself who that expert is and what that person's loyalties are.
Mm-hmm.
So that plays into it as well. The person may be brilliant, but he may be his political fealty might actually overrule his scientific acumen. That happens.
Yeah, it's hard to believe that. I hate that happens, but
yes.
it seems there seems to be quite a bit of historical precedent saying that that's happened for a long time.
Yeah. And I think it has to do with the way we view science. Science and history are two fields that we tend to illogically believe that they I don't want to say aren't falsifiable, that you can't argue with them. People will say, well, it's science, you can't argue with science. Oh, yes, you can. Because some science is performed better than others, right?
Right.
Some science is based on better data and better analyses. So you got to remember that the scientists are people too. Yeah. And their beliefs and their loyalties and, their strongly held, strongly held inclinations can actually prevent them from seeing the truth. And so science is only as good as the person who practices it, unfortunately. Yeah. So that adds like another layer of work for people when we're trying to figure out what we should really believe.
Yeah, it's to me, it seems that it's difficult to hear some of these stories and to hear that even today, it's 2020. Why are we dealing with this now? Like, isn't this something we should all be moved beyond? And I think about how that's true in the United States, but I know in some of your research, you've seen that it's like this in other countries too, where that racial disparity exists in medicine in other places too. And so it's not just a problem within the United States.
Oh, so true. You got to remember that countries in the global South, many of them have fallen victim to what I call biocolonialism. Mm-hmm. It's researchers from the West, from our country, other developed countries that go to these countries and impose on them, not only exploiting them and their resources, but they impose our systems and our culture on them, which includes a belief that their lives are worth less than the lives of white people in the developing world. And so they're treating them differently. So it's no surprise that if you go and look at research done, say, in Brazil or Nigeria, you're going to find abuses carried out by scientists who are U.S. scientists from U.S. universities who are conducting studies and it's very sad what's happening because the studies are conducted in a way where the people in the other countries, developing countries, don't have the protections that we have.
Mm-hmm.
They often don't have informed consent. And they're often involved in studies where the risk is greater than would be tolerated here, or the design of the study separates more of them from treatment. And you end up with people in the developing world being widely used to develop drugs more cheaply and quickly for us in the West. But once the drugs are perfected, they can't buy them because we price them out of their reach.
Yeah.
Sometimes, yeah, so it's really unfair. You got the risk being assigned to the people in the developing world, but we reap all the benefits.
Yeah, it's outrageous. I was in researching a little bit to prepare for our discussion today, discovering that people who are putting their lives, their health on the line, you would think that they'd be taken care of first in exchange for taking those great risks. But to find out that that's just not true, that
Right.
just as soon as it's discovered that something is safe, it is immediately made unavailable to the very people who helped us to get it to that point.
Exactly.
Let's talk a little bit more about informed consent and where we are with things with COVID-19, because obviously we're in the midst of it. We're in the middle of this mess, right? And it's the bodies are mounting, the illness is mounting. What do people really need to be asking themselves, in your opinion? You ask great questions. So, what do we need to be asking about at this point, in your mind, when we're thinking about the role of race and COVID-19 and informed consent?
There are so many questions, but there are several arenas where informed consent particularly troubles me.
Mm-hmm.
Number one, many people seem unaware of it, but in some cities like Newark, EMTs are opting not to administer CPR to people with coronavirus. They're concerned about becoming infected themselves.
Wow.
That's a real concern with any infectious disease, but we haven't heard it discussed or adopted as a policy since the HIV epidemic. Another infection that we didn't understand very well. And so fear of the unknown is playing into this as well. Yes, it's infectious, but people are also worried because they don't know what's going to do to them long term. And yet we have this unfortunate displacement of priorities. The EMT should be concerned about the health of the people whose lives they're being called to help save. But their concern about their own life is making them withhold care from these people. And this is all happening without transparency. The people who discuss this, decide it's an appropriate policy, they're all people in the field. Laypersons, we're the ones who'll be affected by it.
Mm-hmm.
And nobody's asking our opinion. We're not allowed to weigh in. And we often, typically, won't even know that it's a policy until it affects us.
Why do you think that this is happening at a time when we have the ability to communicate through so many different methods, so many different types of media? We have the ability to talk to everyone, anyone, all over the world whenever we want to, and yet we're not having these critical discussions. Why?
You would have to ask the people who are withholding the information.
Mm-hmm.
I can't read their minds. I can't speak to their motivations, but I can say that when you choose not to let lay people know that these policies are being discussed and put into practice, when you choose to enact them in secrecy, then the foreseeable result is that you won't get pushback.
Yeah.
You may not even have this policy exposed.
So Judy, I see Judy has a comment over here. She says, during the initial HIV crisis, I met with the representative for Finnmark, Norway. She said Norway had decided to counter it by doing the exact opposite of the US, which, in my opinion, was to ignore undervalued people. Interesting. So, it's fascinating because I hadn't even thought about the role of the EMT with COVID-19 and what was happening in these life-saving, for the life-saving measures that were being taken. But honestly, there are so many moving parts that, it seems like there's this, and I know that we have to protect people who are going in for medical treatment, but I almost feel like because it's so invisible, because the hurt and the harm is so invisible to people, that they're not understanding the intense impact that it's having and just how devastating it is.
Right. Well, another thing that's happening is that hydroxychloroquine, when it was being administered so widely, including in research studies in Detroit, there were doctors giving it to patients without telling the patients they were receiving it. And they were telling, at least one doctor explained that he did not tell his elderly nursing home patients nor their families that he was giving it to them because he didn't have time to talk to families on the phone. He said, that's all I would be doing if I called the families on the phone. So he gave it to these patients, claimed that he had good success with it, but only within the week, a study in Brazil found that I think 11 patients died and the really poor effects, and the FDA had withdrawn its approval of hydroxychloroquine within a week. So it wasn't performing that well. And yet people died in the study, never knowing that they had taken it.
Never knowing they were in a study, right.
So this is completely unacceptable. And, he might argue not everyone who had it was part of a formal study. It was actually legal to give it to patients because the FDA allows a doctor to give a drug for off-label use.
Mm-hmm.
Okay, but you still have to tell the person, this is off-label use. The drug was a drug actually devised for malaria, but I think it might help with your, your COVID-19 infection. But if you don't tell the patient that's not informed consent. So that's another case. And the worst cases to me are those cases where there is a limiting, inappropriately, I think, called triaging sometimes, because that's not the point of triage, but a limiting of care, withholding of medication and treatment to people on the premise that they are elderly or they have a poor quality of life because they're quote unquote disabled. Now, people who make these arguments for this often adopt what you call utilitarian arguments, a shorthand being the greatest good for the greatest number.
Mm-hmm.
Yes, these people will die, but it's better off for all the other people. Well, that's not ethically appropriate here. First of all, that utilitarian argument is like a tyranny of the majority. Is it right that disabled people should receive lesser care because most of us are not disabled? No, it's not. So this is happening. And there was at least one case in Texas where a man was, I think only 46 years old, close to his family. He had been disabled by a heart attack about 3 years earlier in a wheelchair, and the doctor refused to give him appropriate treatment. He was in an ICU. The doctor moved him to hospice care and told them to withhold food and water, and he died within the week.
That's horrific.
It is horrific. And what's horrific to me is why we know about this case? Because his very intelligent wife, very smart woman, talked to the doctor when the doctor told her, and she said, because my husband is disabled, he has no quality of life. And the doctor said, that's correct, And the doctor said he would do it without her consent. She was taping him.
Wow.
He had it on tape. But how many people will do this? How many people, in fact, will have a chance to talk to their healthcare provider? Because, of course, with coronavirus 19, many people are barred from hospitals and nursing homes. When my aunt was hospitalized, I'm her healthcare proxy. I couldn't go visit her in the ICU. I had to talk to her caregivers on the phone. And with both me and my cousin calling relentlessly, very difficult to get someone on the phone, very difficult to get a consistent picture of what was being done. You felt totally impotent, There was very little you could do. And you are dependent on the information people choose to give you.
Yeah.
So it's a very difficult situation. We have no idea how many people are suffering the same fate. There's
Right.
no way of knowing. And that terrifies me as well, because having it happen once is bad enough. But to my mind, he represents many people that we will never know about who've had the exact same experience.
Well, especially since the communication is so limited from the patients who get COVID-19 to the ability to talk with their family members, to family members being able to talk to medical personnel. I mean, it's just the communication is so strained in all of those connection points that it's hard to really get end-to-end clear story about what's going on.
Exactly. And if you can't communicate with a family, with an elderly patient, like my aunt, then you can't do informed consent, because very often these patients are not capable of informed consent, even when they're well. But when you have coronavirus and you've fallen into a coma, or you're ventilated and can't speak, now the only place to do it is to talk to the family members. And that's become strained and, if not impossible. So, informed consent is seriously threatened by the way we're approaching coronavirus 19 treatment. And what we see historically is that once there's a breach in informed consent, we make exceptions, like exceptions for not having to do CPR.
Right.
They tend not to revert after the emergency. There's something called function creep, in fact, where they tend to expand into other areas. Today it's EMTs treating coronavirus. Tomorrow we'll be facing with EMTs faced with, just regular influenza. We don't know, but there's a danger there.
Yeah. And so that is such a dangerous thing, because really just anyone, this is not a laughing matter, but I'll admit to something. And that is this, that when I went in to have my daughter, she was early, so it wasn't a planned thing, but, we going through the emergency situation, I end up back in my room. She's fine. I'm fine. But I asked my husband to get my makeup bag, and he said, "Why?" And I said, "I have to believe that if something goes wrong, that if they think that I look better, that they're going to try harder to keep me alive." And, I would joke about that, but there was a real fear there. I didn't sleep for 3 days. I was really worried about it.
It sounds prudent to me.
But, yeah. I mean, what you're telling me, though, is that these decisions that we depend on other people to make these decisions all the time. And if there is that creep where it begins to be okay to not try your hardest to keep a life going, where does that stop?
I agree. I think that was smart what you did, actually. Really, I would think the same way.
Yeah.
But studies have shown that in general, because it doesn't apply to everyone, but in general, doctors tend to underestimate the quality of care of people who are disabled. They make an assumption that their lives are not worth as much to them or others, but there's no way you can know. And they're going to rely upon appearances. That happens. It's not fair, but it happens. And got to be realistic about that until we do a better job.
Wow. Well, what does that mean for, there are a lot of people who are association executives who represent industries of all kinds right now who are listening to this. And I know, addressing systemic racism has become the leadership question today, aside from like, how are we going to keep everything going and the lights on, right, keep people employed. It's this question of, wow, Black Lives Matter has brought all of these issues of systemic racism to the forefront too. And while people are listening to stories like this, how can they begin to apply this to, the way that they're leading their own organizations? How can they begin to apply this to, some of the questions that they're asking themselves?
I think one of the big shifts in perspective that can yield a lot of fruit is that to stop looking at behaviors of African Americans through a lens of pathology. That's what people tend to do. That's what public health experts tend to do, in my opinion. They tend to, I'm asked every day, what can we do to make African Americans less fearful? What can we do to make them more likely to take a vaccine when it's developed? How can we make them more likely to engage in medical research? The wrong questions. Don't ask how to change African American behavior. Ask how to make the system more trustworthy. If you have a more trustworthy system, people will trust it. That's the crux of the matter. And so the focus on African American behavior, I think, is eclipsing the other half of the solution, which is that we have to make a system that not only will not treat people differently because of their race, but will be known to do so.
Right.
When you have that, people won't fear it. Until you have that, I can guarantee people are going to avoid the system when they can. That's actually a prudent thing to do.
I mean, I understand it completely, because I have to say that I worry about it myself. I think when people start talking about trust and they start talking about transparency as being an answer, I think, okay, it's a tactic, right? It's a tactic, transparency is.
Yeah.
But I can tell you that if I have to see every little thing to trust that you're doing what you're supposed to be doing, there's still a trust problem there.
Right. That's a very important distinction. It's very critical.
And so it's the intention, it's the care, what's your intention behind what you're doing, and can I trust based on your behavior, based on your competence, based on all kinds of things? Can I trust that you're going to do right by me?
There are things that the healthcare system, I don't want to say makes researchers do, but pressures on researchers to do certain things. And these are the very things that tend to engender distrust. For example, because of the architecture of the system, medical research in communities of color is often conducted by people who are only going to be around for a few years. They're medical residents. As part of their training or as part of a project, they have to do certain research and get an income. 2 or 3 years is not enough time to establish trust. But more to the point, they have an agenda. The community they're descending on knows they have an agenda. And after they have collected what they need, they disappear. Not conducive to trust. And yet I understand why it happens, because if you're a medical resident or if you're someone doing research in an institution, you can't change the institution's architecture to allow you to stay there for 20 years and do the same research. So the thing I always advise universities, find a way to establish a permanent or very long-term presence. Even if that particular researcher will not be around for 20 years, make sure that your institution is there, and then become more involved with the community. Now, I very often read about strategies like going to barbershops and going to hair parlors and going to places, churches and places where African Americans congregate. I understand that. I understand it's practically a good move. But in terms of establishing real trust, and better communication, it's not nearly enough. I think it's important to find a way for your institution to establish a presence and to make it more reciprocal. The researchers I've talked to who have been the most successful, most of them white, in working long-term with these groups have said to me, these are people who, they say, I go and I don't just go to the barber shops because several of them use the term patronizing. I'm not sure it is, but I knew what they meant.
Yeah.
They said, I don't just do that. I said, that's formulaic and people can see right through that. I said, but I will go to places where they actually congregate. One of them spent a lot of time at a settlement house, like basically a neighborhood center that had been there for decades to help people in an area that was very, very poor. He would go there and he would volunteer to talk to the young men because there weren't many programs for young men there. But he said, the bottom line is I also ask people when I'm describing my research, I say to them, what do you need? I can't guarantee I'll get it from them. But if I find out what their needs are, what their priorities are, I do my best to try to get them some attention to that. And they know I'm trying to do that. So it becomes more of a reciprocal situation and less of an exploitative one. So I thought that was really good advice, and it certainly worked for him. He was a white researcher who worked in sickle cell disease for, I think, 15 years in the same community and got great research participation because they trusted him. And he had shown himself to be trustworthy. You know, he was involved with them. He found out the things that they wanted, tried to get them for him, and they would see him all the time. He didn't disappear after 3 years. So,
well, you know, I think that's excellent advice, though, that the actual relationship building, believe it or not,
right.
it counts and it matters, and it ties to better results, you know. So you're talking about building actual relationships, which
Exactly.
is a very human thing to do.
Right. But you know, a researcher would have to go the extra mile because the system does not have that built in, you know, and so you have to figure out how to do it where you are.
Well, to that end, you know, I was really happy to read about how there are different medical schools that are starting to make efforts to incorporate knowledge and about some of these issues that I guess have been invisible for a long, long time, and to many still are. But I was reading about how there's a book club that started up, and this is just a recent article that I ran across, that the book club was focused on your book, Medical Apartheid, and it had completely transformed the young doctors who were reading it, and it was just changing the way that they were planning to practice medicine. And I wondered, you know, what do you think about that when you hear stories like that, and you hear that people are starting to make these changes, and you know that that's going to change the impact that they have on every life that they touch? How do you feel hearing that?
Well, that's why I do what I do. That had been my, you know, hope when I wrote Medical Apartheid, because I knew that the history of medicine canon had been curated in a way that was basically censorship, you know, and I knew that history had to be supplemented with things that had been intentionally deleted from history. And I knew it would change the way young students and young practitioners would see their role, because we have to remember that medical students are trained not only by textbooks, they're also trained by watching their attendings, their, you know, their residents, the people who are training them, and they learn by seeing how Black people are treated, how to treat them. You know, there's certain things that you won't find in a textbook. I mean, the reports are consistent. Half of all medical students believe that African Americans don't feel pain the way whites do. But you won't find that in a textbook. They believe that because watching their senior doctors treat patients, that's what they see. They're being tacitly trained in that. So I wanted to counter that, and I'm very gratified, but it's been going on for a while, actually. In 2005 or thereabouts, maybe it was a bit later than that, but University of Chicago actually supplemented their medical school program by having people come in before the formal beginning of medical school. They added a month to the program, had people come in like me and others to talk about their work and talk about the neglected aspects and the underserved people and the marginalized, or people coming and talking about issues pertaining to gay people, disabled people. And I love that approach because that way the students were kind of inoculated against some of the things they were going to read or experience later on. So it's been going on for a while. I'm very happy to see it's escalating. And I was active in that book club on Twitter, but there are quite a few others going on.
Yes.
And so I'm really happy about that. To me, that's the entire point, to make physicians and incipient physicians question what they're being told about African Americans and who they are and how they should be treated, and to understand that there are abuses that are not always obvious, but are extremely important in terms of affecting how people fare medically, their medical fate, but also how they're perceived by others. So
I had another question for you, because in hearing the story about how you've dealt with acting as proxy for someone who's dealt with COVID-19, for those of people who are watching right now who are maybe wondering, wow, I don't know what questions I should be asking if something happens, if somebody were to come and take me to the hospital right now or something. I don't know if I'd be prepared to protect myself. So if you were taken, like, what are the questions you think people should be asking right now to make sure that they're protected?
Well, I think the first thing one should do to protect oneself sounds crazy, but it's not. Make sure you have a primary care physician.
Mm-hmm.
Younger people sometimes think they don't need it. You're still young and healthy and you're still immortal, right? But you still need one, because a doctor not only cares for you, he also becomes your advocate in the system. Also, have someone you're close to. If you have a spouse, perfect, fantastic. If not, a family member, someone who you not only trust, but will be able to speak up for you when you can't speak for yourself.
Mm-hmm.
I think that should be uppermost in your mind. Who will talk for me when I can't talk for myself? Who knows what kind of treatment I want and don't want?
Right.
So that's really important. And then tell that person what you want.
Right.
Once you go on a ventilator, you will absolutely be I don't want to say at the mercy of, but you will absolutely rely upon your primary care physician, perhaps, but definitely whoever you designate as your health proxy. That person will speak for you, voice your opinions, decide the limits of your care. And then after that, that's what you can do that's within your power. The things that are not within your power, the things that I'm concerned about, and I've been speaking about, whether you get full treatment, whether your DNR is issued without asking your opinion or your healthcare proxy's opinion, you can't control that, unfortunately.
Right.
Whether the hospital's extremely busy and you're going to get the attention that you should get, whether the doctors are going to believe your symptoms. With African Americans, it all too often happens that they will report symptoms, but doctors will not give them full credence as they should. People have been sent home, when they should not have been sent home. They've had their pain not treated, things like that. There's not much control you have over that, because normally your proxy, your advocate, could go to the hospital and voice your opinion. But now with coronavirus 19, with people being barred from the hospital, which I understand, I mean, they have to do that. It's reasonable. I do understand that. But now it's those things you can't control. But the things you can control are having a primary care physician and having a proxy who you have thoroughly informed about what it is you do and don't want done. That's
Excellent.
The best thing you can do.
Yeah, thank you for that. Thank you for that advice, because I think that's a wonderful way for us to start to feel a little bit more prepared, I guess, for something that it's just almost impossible to prepare for. But at least we can do that much and look into that much. If we look at the long term, and this will be my final question for you, if we look into the long term and we start to think about how can we make these changes now to make things better. We've talked about an awful lot that's just wrong, but what are some of the steps we can make to make things better?
Well, one of the worst things that happened is something I think is hard to prepare for, because it's hard to believe that it would ever happen. Quite frankly, I am shocked that any leader would dissolve the panel whose job it was to do surveillance and make a plan for a pandemic, would refuse to listen to the nation's top public health and epidemiologists who gave him consistent advice, refused to make sure that we had the most basic protective gear. That sight of healthcare workers and hospitals having to jerry-rig masks, That should not happen in a country as rich as ours. These are all things that I would never have anticipated, and yet they did happen. So apparently, we need legislation to make sure that the next, and there will be a next one, the next outbreak, we're going to have these basic things done. No one should be able to circumvent these basic public health steps.
Yes.
Then the other thing we need to do is to stop assuming that socioeconomics can convey all the data that we need to determine who's most vulnerable. It can't. We've learned that. We're looking at socioeconomic data in this pandemic, and we got blindsided when it turned out that African Americans and people of color were at high risk. We weren't looking at that. We're looking in the wrong direction. In the future, not only do we have to collect much better data of all kinds, this is basic stuff, not complicated, but we also have to look at racial data early on to make sure that we don't end up with another pandemic that's racially stratified, and we're caught, it's too late to do anything about it now, frankly, but it wasn't too late in February when we should have been looking at the data. So we have to do that.
Yeah.
And then we also have to be vigilant against this erosion of informed consent. It's during emergencies, like infectious disease emergencies and wars. That's when the greatest threat to informed consent arises. People begin saying, it's an emergency, it's urgent, we got to do something now. And that becomes the gateway for all kinds of abuses. We also need written legislation governing when we do and do not dispense with informed consent. We should not be able to dispense with informed consent just because somebody thinks they might not be safe doing CPR, So we have to have, we should not be debating these things during the pandemic. Think about them now, make decisions on how we're going to handle them and mandate them, and then stick to them when the next outbreak hits. That's what we should do. One of my favorite mantras is, when you lose, don't lose the lesson.
I love that. Yeah.
And unfortunately, I think that there's been a lot of failure around this pandemic, and the best thing we can do is learn from it and make sure it doesn't recur. And we can do that.
When you lose, don't lose the lesson. Oh, that's a good one. That's a good one. I really appreciate you taking the time today. I do. It's just been such an informative session. It's sad. A lot of these things, you write about a lot of things that are sad.
They're hard. They're hard, but I have hope. You got to confront things if you want to change them, make them better.
Yeah, well, and that does give me hope, because the fact that there's a you out there that is writing and studying this and making sure that we have these conversations, making sure that we have a place to turn when we need to find out more about ways to improve. I'm thankful for the research that you've done, and I'm just really grateful that you took the time to talk with everyone on Association Chat today.
Thank you so much, Kiki. I've enjoyed it.
All right. So everyone, I just thank you for joining us today. This has been enlightening for me, and I'm really looking forward to creating the summary around this. I hope you will go out and get all of Harriet's books. You can look Harriet Washington on Amazon.com or any bookseller. There are a ton of them that are out there. And until next time, everyone, let's take care of each other. Keep asking questions to learn every day. And as Joseph Campbell once said, the cave you fear to enter holds the treasure you seek. All right. Have a great rest of the week.